Thank you very much, Jose. And I will just start to just introduce our next speaker for Lighting Talks. So directly from Lyon, France, it's my pleasure to announce that Dr. Isabel Sergio-Mataram will speak on inequality of cancer burden in different European countries. Please, the floor is yours.
My name is Isabel Suryo-Mataram. So I work in a WHO specialized agency on cancer. We are a separate institution where we then study. We're doing research on cancer, while WHO role is much more than in the advocacy relationship with governments, policy making, and so on. Our institution is really mainly a research-based, dedicated institution. That said, I work even more in detail on the cancer data. I work a lot on cancer data using cancer registry data. I'm not using that much hospital-based cancer registry data. What we use is much more than population-based data. So the data that we retrieve we try to collect are data that are really covering the whole population of a certain areas. In Europe, like Nordic European countries, usually this cancer registry covered then the whole country. So everybody who's living in the country would be part of that registries, and their data are then being collected. The data are quite general. We're trying then to improve the data by getting more detailed data. But then in some countries that are bigger, for example, just to name France, then this population-based cancer registry cover a smaller part of the country, but then they try to be representative. And that's the same case like in Spain or in Italy. So today I will then speak about liver cancer in Europe. I added inequality, but the idea is then to say differences in Europe. I think everybody knows this. Every country is so different, and even within the country we see differences. Northern France and southern France, we believe that it's a very different part of the countries. And that's true for a lot of other countries in Europe. So using the differences that we see in Europe, we can learn really a lot from each other and use it to improve life of cancer patients, reducing the liver cancer burden in Europe. I'm not going to touch at all in within country differences. I will only focus then differences between countries in Europe, because I think there's enough variation there where we can then take a lot of key messages to learn from each other. This is a map that I showed earlier this morning, but this is a map of liver cancer incidence, so the number of new cancer cases in Europe. And this is already corrected by the number of the population. So countries that are bigger are not going to have darker color, because it's divided by the number of people living in each of the countries. And this is then data for new cancer cases in both sexes combined, so women and men together. And then we can see just from this data that in some parts of Europe, there's really low numbers of liver cancer. So new liver cancer cases, it's below 3. And then if everybody, some of you work with rare cancer often is defined below 4 or below 6. So in this country, liver cancer is one of rare cancer diseases. Well, then in some other countries, we see then almost 10 per 100,000. And then that you see a lot then in Southern Eastern European countries. If we see this number then for males, so now we're looking at the map for males, it's quite similar. Males have a much higher rate than women. So then if we see here, then in those same countries that were blue before, the number goes up, it's even more before 10, but we see that very same differences as what we saw before. And then in some countries, it is then around 4 or 5. I mean, this is a difference of 3 times. So in some countries, they managed to reduce the liver cancer incidence or new cases less than 3 times of the other countries. So that's a lot. This is in men, and then some people say, okay, women, they're much more wiser. But then if you see in women, we see similar differences. It's much less than what we saw in men. In men, we have then up to 15. In women, there is a lower rate. So we always then see male to female ratio. It's about 3 times. And then here, then we see exactly that. But then the same countries or very similar countries where then the men we saw a higher rate of liver cancer, we see that as well then for females. So both male and female, you see a bit of the similar pattern in terms of liver cancer in Europe. Some Southern Europe, Portugal didn't come up. And then here you see then UK having somewhat of a higher risk. So for me, again, this just showcase at least two important messages. Some countries manage to make this lower. It means there's an explanation why those countries have it lower. And we're talking about incidence, so we're not talking about some countries are better at treating their cancer patients. It means that some countries are better at preventing these cancers. And whether then it's the people, the patients, or then the government, I think both of them are important factors at reducing then the liver cancer cases. So it means that we can do something about it. So this is then my key message. So liver cancer is preventable. If some countries manage to do it, other countries manage to do it. If some people manage to do it, other people manage to do it also, even though if we're from different European countries. But then the next question is how. There's a lot of discussion already now on, especially then on the screening, so trying then to detect it earlier so then it can be treated also more adequately. I'm going to concentrate only then on the risk factors, so really then preventing the cancer itself. We already mentioned then a few risk factors, and then I would like then to go to the next part as well, that Europe is different in terms of the liver cancer burden, but if you see that next, in terms of the risk factors itself, every country is a little bit different as well, meaning that we need to do something a little bit different in every country. So how are we going to do this? I saw that then previously we were planning to have someone coming to talk about the European Code Against Cancer. So I'm not going to go through in more details about this. All the information on what can be done is available. And then I saw as well in the EASL website, there's quite a nice infographic on what people themselves can do. So this is European Code Against Cancer is really then recommendation that is really adapted for people. So for us, for the public, what can we all do to reduce the risk of getting cancer? So the first factor that I wanted to get into is tobacco smoking. So we mentioned this already. So this is, if you see the map on the left, is then for men. So you see then the number or the proportion of liver cancer in different European countries that can be attributable to tobacco smoking. And then you can see then in men, in some of the Northern European countries, it's light blue, meaning that they're doing probably really, really good in tobacco smoking. And we know that the tobacco smoking rate there is really low. Well, then in the Eastern European countries, I mean, this is it's a third of liver cancer could be attributable to tobacco smoking. This is really a lot. And then we know really well what works to reduce tobacco smoking in a population. If we're talking about female, we see a bit of a different pattern. Before then, we see Northern European countries having kind of the lighter blue, or they're doing really well in terms of tobacco smoking. But then in the Northern European countries among women, we are seeing then a higher proportion of liver cancer related to tobacco smoking. And then if we're seeing then more to the left or to the Eastern Europe, and then it's much less. And then the proportion is then also lower. So then tobacco smoking is still today more of a habit that is among men, and more than a risk factor much more for liver cancer among men. But then 15%, reducing 15% of liver cancer, for me, it's a big number that we can do something about. The next one, we mentioned this as well, alcohol use. And then this, again, we see something a bit different than what we saw before. Well, before we see then a lot of things that we can do in Northern Europe or then in Eastern Europe, for example. Now for alcohol smoking, we're seeing then Russia, for example, where then the alcohol consumption is quite high. But then again, it's 30%, it's a bit lower than tobacco smoking, but high nonetheless. And then we see that higher than alcohol consumption that at the end is related to liver cancer. In France, we know this, in Germany, and then some also then of the Southern Eastern European countries. And then we see that then for females in Germany, and then really then a big portion of that in Eastern European countries among women. So just using these two risk factors, really important risk factors, really then factors that we know how to get them down, to reduce them in the population, either than asking the population to be more aware, but with a lot of then governmental policies, we can then do really a lot in reducing liver cancer. The last one, so this is already also mentioned really a lot, especially in the previous session, hepatitis B and C. So this is then a number only for HCC, so I'm not including liver cancer as total as what I showed previously for tobacco smoking and alcohol. So the number would then shrink a little bit, but most of liver cancer is HCC anyway. And then here, then we see, this is then the number, of course, that comes from today. Hepatitis B vaccination has been deployed, and then it reaches a big number of the population, but there's also, of course, part of it that hepatitis C as well. And then here, then you see a really big number. This is where then we also get really big gains in terms of if we want to kind of target reduction of liver cancer. Here, then we see much more similarities between men and women. The numbers are also very similar because then in terms of hepatitis B and C, there's quite similar risk of transmission of these two viruses. So just to conclude, and then I hope that makes then my point clear. We see really large differences in liver cancer in Europe, and for me, it just shows that there are large differences in the causes, but also then probably large differences or stronger prevention programs in one country and then as compared to other countries. These differences, however, also then give us an idea on how to prioritize in terms of prevention program. It seems, of course, then all the prevention programs are similar because the causes are similar, but then using this kind of data, countries then can say where then they want to put much of their advocacy into, what can they do, and with what have then the biggest impact. We know that the number of cases will increase, so prevention is important. It has to be done alongside of the other approaches, screening, early detection, and management of patients. And then I also then want to reinforce that this kind of information data, the presentation from Pierre used a lot of it, population data as well. It's really important to plan, but monitor and also evaluate what's happening, as what we saw on how then some of the liver cancer or HCC has been decreasing in some countries where then the vaccination started earlier. And then as we are talking now to different kind of people, I think everybody can make a difference. Patients can make a difference, not only by advocating prevention or early detection, but also then advocating use of data, advocating asking to the government to do more. And then now as a patient advocacy group, doctors, families, friends, everybody can make a difference in really trying to reduce the burden of cancer, especially in this special day, the World Cancer Day. That said, thank you so much for the organizer for listening, especially Joanna, who's really then been very dedicated in organizing everything, but all the interest groups who are here and more, Cancer Registries for sending the data, and Jerome for helping me. If you want to see more data, more details, it's all available online. Thank you so much for listening, and let me know if you have any questions.
Thank you, Isabella. That was absolutely fascinating. It really was. And it just goes to show, it proves how important information is. So I'd like to invite all the panelists back now for some more questions. If anybody out there has got any questions, please put them in the chat box and we'll monitor them as we go along. I think firstly, actually it's you, Marco, on the top of my list. You have a question, I can see.
So I see the first question from Ingo, and he put it in the chat.
Already, sorry.
Yeah.
That's quick off the mark, Ingo. No, I don't have that.
So I will read it out loud. So Ingo is saying, fascinating but troubling data on tobacco and HCC. More studies should look into this. So did you see big overlaps of tobacco smokers who had also excessive alcohol use? What about other overlaps, for example, alcohol and tobacco and viral hepatitis, which can also be found especially in high-risk groups? Were these cases easy to tell apart?
So far, that's one of the limitation of a lot of our studies. We've done a lot of the work one by risk factors, but we know from just looking like what you said, Ingo, that it's really, they're all overlapping. So this is only looking at those people who smoke or those people who drink alcohol, for example. Imagine if we're looking then the risk and the impact, because these people probably are often together. If you smoke and then you also drink, probably then the risk would increase. And then of course there's all other comorbidities that usually these patients would have. So that would be a really nice research questions. Would love to do it in the future, but really good comment.
Thank you. Thank you. So Marco, you have a question.
Yes, thank you very much, Rachel. But prior to going to my question, we have 2, 3, 4 questions in the chat. So
actually in the chat, I didn't have that.
Okay, if I just can read the last one from Maria Arage. What do you think about coffee? So
there's some studies now, Maria. I love coffee, so I would be worried if coffee is. There's a lot of research here looking into coffee drinking, and every time they're doing it, I want to stop. Well, no, okay. Every time they're doing it, I'm very interested in the results. We know that there are some studies that show that coffee is decreasing the risk of liver cancer. I don't think we should then take this as one of the preventive measure campaign. I think we should take this home as a relief that tomorrow morning we can still drink our coffee and then start our day awake.
Yes, indeed, there are some studies that demonstrated the impact. There are, again, the confounding factors around those people who usually drink coffee, maybe also smoke and drink alcohol. But there are several studies in this regard, and some guidelines recommend or consider the coffee intake as a preventive factor for HCC. So just to have something good, if you stop drinking alcohol, stop doing many things at the same time, you could drink coffee.
Your coffee, yes.
Yeah.
Okay, so we've got another comment here in the box. It's actually from Akim. So in comparison to other cancer, HCC is on the rise. How is IARC reporting that to WHO or to the EU?
So this morning I had another discussion with Marco on this. So indeed, liver cancer, we're talking now about HCC, but as well as cholangiocarcinoma. So both of them, we're actually seeing increase of this cancer, especially in many European countries. Well, then actually we have been seeing decreases in these two cancers in other parts of the world. Now, taking an example of Japan that's doing so well, you see actually those cancers decreasing there. So we're bringing this over, we're putting the data publicly, and then hoping that WHO will bring this forward. But again, this should be done not only from our side, but also then in collaboration, for example, with groups such as yours, EASL, but also ELPA, and a lot of patients group, professional group. We need to do something on this. Otherwise, yeah, we'll just see more number of cancer cases increasing in Europe, and that's really not an option.
No, no. And I think education and raising awareness is really key to all of this. Being able to share that data, it really brought it home. There's a quick comment from Ingo who says that there's actually several guidelines to recommend coffee, not that we're here to talk about coffee, including the German NAFILD guideline. So we don't have to stop drinking our coffee, which is such a relief. Thank you. There's no more comments for the minute. Marco, do you want to go with your question now?
Yes, thank you, Rachel. Thank you very much. I just wanted to add to the coffee also tea. I was wondering, because we have several people from UK, maybe tea is also good for liver. And when you are thinking about what to say about tea, the question that we got from patient representative was also, how do you see the differences in healthcare systems? Because we are so different in Europe. Do you have any recommendations, or do you see something that was done really good elsewhere and we can replicate, or how to overcome the differences in healthcare systems?
I think many countries are doing really good things. Just taking the example that Pierre mentioned previously on Japan, on how to do screening program, for example, but in different European countries, there's also different bigger system strategies and plan to reducing cancer. I know that in France, they've been very quite aggressive in increasing, for example, the price of tobacco. And this is not coming from the Ministry of Health, meaning that the whole system itself needs to kind of work together to be able to, at the end, have an impact on liver cancer, a really long-term impact. But then also on alcohol, it's tough to do something about it, but there's a lot of different countries that have been doing really well in reducing alcohol. UK, Scotland are doing really impressive work in terms of reducing alcohol, but tobacco. So I think we really need to learn from each other, because even in the most, Scottish and drinking alcohol, you almost can't separate that, but then they manage to do it. It means we all can do this.
Isabel,
yeah,
can you comment about how the countries collect the cancer cases? So there are very big difference in the way that they collect the number of liver cancers, and probably this could impact at the end on the results.
So countries collect them differently, but we're talking now really European countries. Yeah, so European countries are actually one of the champions in collecting data. They love data. So in terms of collecting the number of cases, I think these countries are doing a really good job. So I'm not that worried thinking of the numbers are not good or whatever. What would be nicer is that, as everybody mentioned, liver cancer is not one single disease. If we would be able to get the liver cancer separately by the different liver cancer, that would be even better, because we know HCC is caused by something else. The diagnosis Maria just mentioned should be done also differently. It would be nice to have better data, more detailed data beyond just liver cancer. A lot of the data we receive it also from death certificates. And then when you get the data from death certificates, you get very general causes of death, okay, liver cancer, and then we can't get further whether it's HCC, intrahepatic cholangiocarcinoma, or other Klatskin disease, etc. So it would be nice if the process would be better, that we can get more detailed data. We're working on it, but at the moment, I think much more of the challenge is getting more detailed data rather than improving the quality of the number of cases calculation.
Can I make a comment in this regard? For me, the most important thing is the diagnosis of HCC majority is done without biopsy. So the registers of HCC sometimes is misunderstood or misregistered. So the impact of the disease in our community, it is biggest as the number of the register. Because if you follow a register based on pathology samples, the number of cases are completely different as if you compare with the general population with cirrhosis and who develop liver cancer. And this is something that is important to keep in mind.
Yeah, I completely agree. So for a long time, cancer registry depend a lot on pathology, pathological reports. And then now, because liver cancer diagnosis has changed so much and now using much more imaging, so ultrasonography and so on. So we don't have any pathological confirmation for a lot of the cases, and then they immediately kind of put into another box, which is not correct. So we're trying then to standardize this data collection and then change that habit or practice, so then we're much more comparable in Europe.
Thanks.
Can I ask one quick question there, though? But in terms of, you know, how is this communicated to the general public, to the people across Europe? You know, because, you know, we have people call us up on our helpline and they'll say, well, you know I need to go and have a test, but they think they're going to have a biopsy. They don't understand that anything has changed, and that because biopsy is horrible. If anyone's had one, they'll know. You know, but so the information about the transition and the biopsies aren't needed in the same way. I don't know that it's out there enough. I think that people still think that it's an old way. It's a bit like when the treatment for hepatitis C became oral, and then a lot of people still believed it was the interferon. So, but how can we make sure that people in the communities have got the right information?
That's a question that I would, for us, we do a lot of education material, mainly then for cancer registrars, hospitals, and medical doctors who we work a lot in terms of data collection. But the patient contact, it needs to come a lot from the doctors, but also like association like this, where then there's much more contact with patients or potential patients or people. It needs to be communicated. Maybe in that sense, people are more likely to come for examination, right? If they think that they're going to be biopsied. If I think of my grandparents, they would immediately think twice about it. Well, then if you told them that this is a simple procedure, maybe they're more likely then to come forward. Do you agree?
Give you some, if you want, share you some experience, and you can give me yours, because there are two ways to see things with patients. Sometimes when you say that you don't need the biopsy, patients are happy because they get a sense that it's an aggressive and invasive technique, needs to be hospitalized, and we always make them sign papers with informed written consent saying you can die from a biopsy. So I would say that the old generation of patients is quite happy when the hepatologist or liver cancer specialist say, I don't need the biopsy, I know you have cancer because you have cirrhosis. But I fear now, maybe Maria, both Maria as experienced doctors, maybe you share the same experience. There is a kind of defiance right now with patients. And I am more and more facing patients. When I say them, you have cancer, they say, prove it. I know that cancer has to be biopsy proven. I saw that on the internet. If you're saying I have a cancer because you see an image on the CT scan, I don't go for hepatic resection or ablation or transplantation. I want to see written with words that I have cancer, not only radiology. And I am facing right now more and more patients that will not go into complicated and strategic procedures such as liver resection and hepatic ablation, unless they have the proof that they really have cancer, which is basically done by a biopsy. I don't know, how about you in Spain or Italy, how does it, but I think the younger generation is more defiant with this non-invasive criteria for liver cancer. And I don't know about patients.
If I make my view, we don't have exactly the same perception. It is right that every time have the same, the patients are different, the doctors are different, and we need to spend time to explain why do you need or not the biopsy. Sometimes when the patients read or internet or say that have information, we usually ask where was the source of this information. And we need to spend time, but to explain them that they are not needed the biopsy for this and this reason. And in general, we do not have this problem. The main difference that we have now is we are seeing more and more patients without cirrhosis, or patients who were treated for hepatitis C. They were cirrhotic in the past, but are not cirrhotic at this time. And in these things, the management changed a bit. But I don't have the perception that, at least in the 13 years that I'm working, Pierre now have more experience than me, but I think I don't have this perception. But shared decision with patients is key, and we need to focus on that.
Yeah. I agree with Maria. Perhaps oncologists that are treated patients with liver cancer ask for more histological documentation, but in general, I don't have this feeling, but will change. And regarding a question about hepatitis C and genotypes and the risk of HCC, we know that patients infected by genotype 3, they have a higher risk of developing HCC because genotype 3 is associated with more liver steatosis. But after eradication of hepatitis C, after sustained virological response, there is not a lot of data looking if the genotype could play a role after hepatitis C cure.
Okay, so thank you. I mean, that's something that's come up for us a lot recently. A lot of patients asking because it's quite new information. So what you're saying is if it's genotype 3, once the hepatitis C has been eliminated and you no longer is active, your risk for HCC, you don't need to have regular ultrascans or fibroscans.
If the patient has a liver cirrhosis before or advanced fibrosis, clearly they still need surveillance for HCC after hepatitis C cure. But if you cure the infection at an early stage of the disease, then the recommendation is not to do surveillance for HCC.
I believe that the important message here is the baseline fibrosis before starting the treatment is key for the follow-up. So patient, sorry?
Just to clarify, it needs to be the first 2 stages. You do not need every 6 months examination. In the last 2 stages, 3 and 4, you need every 6 months examination, correct?
Yes.
What do you mean?
For the first 2 stages of fibrosis,
F1 and F2, no surveillance.
no surveillance. For F3
Yes,
and F4, if you need a surveillance.
Yes.
Yes, according to the data that we have today. Maybe in some years when we have more data, because the number of patients who were treated until now are now under screening in some areas.
And professors, we have been talking a lot about hepatitis C, but what about hepatitis B? Why is that?
The information is clear, and Pierre now already mentioned patients who are at risk, high risk of hepatitis B, clearly have the need of surveillance, regardless of the cirrhosis.
No matter the cirrhosis. Okay.
Sorry. We have a hand up. No, if your hand, would you like to?
Yes, I want to make a comment. related to the scary situation that can be to have a biopsy that Isabel has mentioned. I think here the patient education is also the key, because if patient knows what are the risks of the procedure, how the procedure is performed, the logical situation to make her life, you have to stay one day in the hospital or not. This kind of situation are the keys to decrease the anxiety, and this is patient education. And to Professor Naon, I'm surprised about the patients who wants to the demonstration, because I don't know any patient in that situation, but in that sense, some of our patients are not disconfiated, but they feel good. And I think in this cancer, the key is that they feel good. They have no symptoms. And sometimes they have expressed that perhaps the result is from another patient because I feel good. So I think this kind of, please give me the demonstration that my name is associated with this disease, is in this sense, or in this, with this explanation. So in these cases, also to explain them that because you can do a biopsy and it can be negative because the heterogeneity of the tumor. So you have to explain them, and sometimes it's easier for a nurse to explain them because we use another kind of dialogue with them than the physicians do. I'm sorry, but it's true.
There's a question here. It says, do you think it makes a difference if a hepatologist or an oncologist gives the diagnosis to patients?
Maybe Neus is focusing physicians and nurses.
Okay.
She's saying that the physicians are more technical and the nurses have more close communication.
In our case, we have hepatologist oncologists, so there's no difference between, and they have experience with cancer, so the dialogue is similar to the oncologist, as you mentioned.
I fully agree with you when you say that patients do not address the same question to a nurse and a doctor. They have a 10 minutes consultation with a doctor. Usually, for example, me, I'm with the oncology nurse, and then after they spend like 50 minutes with a nurse, and they do not ask the same question. You have those who try to challenge the doctors, and these are maybe the youngest generation who have access to maybe too many information, and sometimes what I call defiant, and saying, you are the doctors, but I think I know as much as you do. And for me, I need a biopsy to prove I have cancer. Otherwise, I do not believe you. You're not a good doctor. But of course, this is a very few patients. But for the classical patients, they go to the doctor, a pathologist or oncologist, and they say, okay, doctor, yes, doctor, okay. And then after they ask the good question to the nurse, am I going to die? How long do I have to live? Do I have to go back to my country? What do I have to say to my children? And the nurse is sometimes put in a bad situation. And this is the whole, I would say, interest of this work of the oncology nurse, and not only oncology, but nurse specialized in liver cancer, because you have all this, and this is also the difference between oncologists and hepatologists. Again, you have two expertise. You have the expertise in liver cancer, but also in chronic liver disease. It's a whole patient, it's one patient and a global liver cancer, but also should you give antivirals or not? What can I do for alcohol consumption to improve liver function before liver resection? So this is a whole management, and clearly, I would say that specialized hepatologist and specialized nurse in HCC are mandatory to optimize this management. So this is my point of view.
Fully agree. The teamwork is the key.
Yeah, and they're all highly valued by the patients. I'm really conscious of time, so I think there was a question that I missed there, Marco. Would you like to go back there? And I think we're getting close to coming up.
Thank you. Yeah, thank you very much. So yeah, we are at the end of our panel. I just wanted to say thank you to also to professors, because you just come to the conclusion that a patient needs to be introduced into the same information from different sources, one being a doctor, second being the nurse, third maybe being a patient representatives, and that way he can remember more or ask different questions. I would like to finish this panel with a request we have from Ingo. So Ingo said that he has one big request to EASL, which goes beyond liver cancer, but it is concerned about the EASL guidelines, which are downloadable for free and should stay that way. But it's a problem with requiring an EASL account. If this is something that can be solved in the future, that would be great, because these guidelines online are very efficient for prevention and also prevention of late-stage diseases and cancer and understanding what is going on. So thank you for that comment, Ingo.
We take notes.
So I think, I mean, I'm not sure if there's any more questions, but I think from here, it's to say thank you very much to Isabella for a fantastic, absolutely fascinating presentation, and then to hand back to Maria, Josie.
Yeah, thanks. On behalf of my co-chairs, thank you very much for joining us today, the Liver Cancer Day. I think the presentations have been great, and also the input received. We are going to take care of the request of Marco and Ingo, and I hope that very, very soon everybody can have the EASL guidelines recommendations free. I think it's an important point. I have enjoyed the meeting. I think the only way to go ahead is working together. This really will improve the lives of liver cancer patients. We have learned today that lifestyle is really important to prevent liver disease. And this implies important changes in the European policies regarding alcohol, tobacco, food, sugar foods, and also increased viral hepatitis eliminations. And if you like to achieve changes, even some small changes that are really very, very difficult, the only way is to work together. The COVID-19 pandemic clearly has important consequences, as Maria have shown. But I think this is also an important point to help and to show us that working together is the only way to go ahead. And yesterday, the European institutions announced the adoption of the European Beating Cancer Plan. So we now have to work and hope that the inequities across the European countries could be reduced with this new plan and could better prevent cancer. Finally, I would like to thank Joanna Nedelcheva. It's our contact point. She has organized and spent a lot of time doing this meeting. And if you need something from EASL for EASL Public Health, please contact with Joanna. We are open to work with all of you in the future and receive your input and your ideas. This is the only way that we can go ahead. Thank you very much and have enjoyed the evening.
Congratulations. Bye-bye.
Bye-bye.
Bye. Thank you all so much.
Bye.
Bye-bye.
Thank you.
Bye. Thank you.
Bye. Thank you.
Goodbye.
Bye.